Hello, today we have lecture number 8, Malignant Lung Neoplasms, Lung Cancer, Risk Factors, Pathology, Classification System, Etiology, Clinical Manifestations, Diagnosis and Staging. Also paraneoplastic symptoms. Risk Factors. Cigarette smokers have a tenfold or greater increased risk of developing lung cancer compared to those who have never smoked. A large-scale genomic study suggested that one genetic mutation is induced for every 15 cigarettes smoked. The risk of lung cancer is lower among persons who quit smoking than among those who continue smoking. Former smokers have a ninefold increased risk of developing lung cancer compared to men who have never smoked versus the 20-fold excess in those who continue to smoke. Although cigarette smoking is the cause of the majority of lung cancers, several other risk factors have been identified, including occupational exposures to asbestos, arsenic, bischloromethyl ether, hexavalent chromium, mustard gas, nickel, as in certain nickel refining processes, and polycyclic aromatic hydrocarbons. The World Health Organization defines lung cancer as tumors arising from the respiratory epithelium, bronchi, bronchioles, and alveoli. The WHO classification system divides epithelial lung cancers into 4 major cell types: small cell lung cancer, adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. The latter 3 types are collectively known as non-small cell carcinomas. Small cell carcinomas consist of small cells with scant cytoplasm, ill-defined cell borders, finely granular nuclear chromatin absent or inconspicuous nucleoli, and a high mitotic count. SCLS may be distinguished from NSCLS by the presence of neuroendocrine markers including CD56, neural cell adhesion molecular, NCM, synaptophysin, and chromogranin. Adenocarcinomas possess glandular differentiation or mucin production and may show acinar, papillary, lipidic, or solid features, or a mixture of these patterns. Squamous cell lung carcinomas of the lung are morphologically identical to extrapulmonary squamous cell carcinomas and cannot be distinguished by immunohistochemistry alone. Squamous cell tumors show keratinization and/or intercellular bridges that arise from bronchial epithelium. The tumor tends to consist of sheets of cells rather than the 3-dimensional groups of cells characteristic of adenocarcinomas. Large cell carcinomas comprise less than 10% of lung carcinomas. These tumors lack the cytologic and architectural features of small cell carcinoma and glandular or squamous differentiation. Together, these 4 histologic types account for 90% of all epithelial lung cancers. All histologic types of lung cancer can develop in current and former smokers, although squamous and small cell carcinomas are most commonly associated with heavy tobacco use. Through the first half of the 20th century, squamous carcinoma was the most common subtype of NSCLS diagnosed in the United States. However, with the decline in cigarette consumption over the past 6 decades, adenocarcinoma has become the most frequent histologic subtype of lung cancer in the United States, as both squamous carcinoma and small cell carcinoma are on the decline. In lifetime, never smokers or former light smokers, less than 10 pack years history, women and younger adults, less than 60 years, adenocarcinoma tends to be the most common form of lung cancer. In addition to distinguishing between SCLS and non-small cell lung cancer, because these tumors have quite different natural histories and therapeutic approaches, it's necessary to classify if NSCLS is squamous or non-squamous because of the recognition that some active chemotherapy agents perform quite differently in squamous carcinomas versus adenocarcinomas and the different recommendations for molecular testing. The revised 2011 classification system developed jointly by the International Association for the Study of Lung Cancer, the American Thoracic Society, and European Respiratory Society provides an integrated approach to the classification of lung adenocarcinoma that includes clinical, molecular, radiographic, and pathologic information. It recognized that the most lung cancers present in an advanced stage and are often diagnosed based on small biopsies or cytologic specimens, rendering clear histologic distinctions difficult, if not impossible. This was addressed by the WHO 2015 revised classification of lung tumors. The distinction between squamous and non-squamous lung cancer is reviewed as critical to optimal therapeutic decision-making. A diagnosis of non-small cell carcinoma not otherwise specified is no longer considered acceptable. This distinction can be achieved using a single marker for adenocarcinoma, thyroid transcription factor first, or NAPSIN-A, plus a squamous marker P40 or P63, and mucin stains. If tissue is limited and a clear morphological pattern is evident, a diagnosis can be made without immunohistochemistry staining. Both classification systems recommend preservation of sufficient specimen material for appropriate molecular testing necessary to help guide therapeutic decision-making. The terms adenocarcinoma in situ and minimally invasive adenocarcinoma are now recommended for small solitary adenocarcinomas, less than 3 cm, with either pure lipidic growth or predominant lipidic growth with less than 5 mm invasion. Individuals with these entities experience 100% or near 100% 5-year disease-free survival with complete tumor resection. Invasive adenocarcinomas, representing more than 70 to 90% of surgically resected lung adenocarcinomas, are now classified by their predominant pattern: lipidic, acinar, papillary, and solid patterns. Lipidic predominant subtype has a favorable prognosis. Acinar and papillary have an intermediate prognosis, and solid predominant has a poor prognosis. The terms signet ring and clear cell adenocarcinoma have been eliminated from the variants of invasive lung adenocarcinoma, whereas the term micropapillary, a subtype with a particular poor prognosis, has been added. Because of prognostic implications, squamous cell carcinoma has also been modified to consist of keratinizing, non-keratinizing, and basaloid, analogous to head and neck cancers. You see this diagram, malignant lung neoplasm, its classification. And tumor types, we have non-small cell lung carcinoma, which localized peripherally and characterized most common type of primary lung cancers. Common in women and non-smokers associated with mutations in AGFR gene, ALK gene, and KRAS gene. Histologically, it's glandular tumor, mucin-producing cells, and lipidic adenocarcinoma growth along alveolar walls, alveolar thickening. Next, we have including in tumor type non-small cell lung cancers. It was the first lung adenocarcinoma. Next, we have lung squamous cell carcinoma, which localized centrally and characterized with strong association with smoking, cavitary lesions arising from a hilar bronchi, and histologically we have solid epithelial tumor, intercellular bridges, desmosomes, and keratin pearls. Next is large cell carcinoma, which is peripherally localized, characterized strong associations with smoking, poor response to chemotherapy, early metastasis, poor prognosis, and histologically it's undifferentiated large tumor cells. Next type is lung neuroendocrine tumors, which include small cell lung cancer, large cell neuroendocrine carcinoma, and bronchial carcinoid tumors. Small cell lung cancer is central localization, characterized with strong association with smoking, extremely rare in non-smokers, associated with several paraneoplastic syndromes, undifferentiated and very aggressive with early metastasis and associated mutations L-MYC oncogene. Large cell neuroendocrine carcinoma is peripheral, and bronchial carcinoid tumor may be central or peripheral. And histology of lung neuroendocrine tumors is neuroendocrine Kaltsky cells, rapid growth patterns, express tumor markers like chromogranin A, synaptophysin, and neuropin-specific enolase. Now about the etiology of malignant lung neoplasms. First is tobacco smoking, which is associated with the development of 80 to 90% of lung cancers. Weak association with lung adenocarcinoma. Next is causes occupational and environmental exposure to carcinogens. Passive smoking, radon, second leading cause of lung cancer is radon. And uranium, radioactively disease into radon. Next, asbestos, then occupational carcinogens, for example, arsenic, chromium, nickel, beryllium, silica, and so on, and environmental air pollution. Next, family history, genetic predisposition. The other risk factors are pulmonary scarring, previous radiation, pulmonary fibrosis, chronic infections, for example, tuberculosis or HIV. Diagnosis of malignant lung neoplasm. Tissue sampling is required to confirm a diagnosis in all patients with suspected lung cancer. In patients with suspected metastatic disease, a biopsy of a distant site of disease is preferred for tissue confirmation. Given the greater emphasis placed on molecular testing for NSCLS patients, a core biopsy is preferred to ensure adequate tissue for analysis. Tumor tissue may be obtained via minimally invasive techniques such as bronchial or tracheobronchial biopsy during fiber optic bronchoscopy, by fine needle aspiration, FNA, or percutaneous biopsy using image guidance, or via endobronchial ultrasound, EBUS, guided biopsy. Depending on the location, lymph node sampling may occur via transesophageal endoscopic ultrasound guided biopsy. EBUS or blind biopsy. In patients with clinically palpable disease such as a lymph node or skin metastasis, a biopsy may be obtained. In patients with suspected metastatic disease, a diagnosis may be confirmed by percutaneous biopsy of a soft tissue mass, lytic bone lesions, bone marrow, pleural or liver lesion, or an adequate cell block obtained from a malignant pleural effusion. In patients with a suspected malignant pleural effusion, if the initial thoracentesis is negative, a repeat thoracentesis is warranted. Although the majority of pleural effusions are due to malignant disease, particularly if they are exudative or bloody, some may be parapneumonic. In the absence of distant disease, such patients would be considered for possible curative treatment. The diagnostic yield of any biopsy depends on several factors, including location, accessibility of the tumor, tumor size, tumor type, and technical aspects of the diagnostic procedure, including the experience level of the bronchoscopists and pathologists in general. Central lesions such as squamous cell carcinomas, small cell carcinomas, or endobronchial lesions such as carcinoid tumors are more readily diagnosed by bronchoscopic examination, whereas peripheral lesions such as adenocarcinomas and large cell carcinomas are more amenable to transthoracic biopsy. Diagnostic accuracy for squamous cell lung cancers versus non-squamous cell lung cancer for most specimens is excellent, with laser accuracy for subtypes of NSCLC. Bronchoscopic specimens include bronchial brush, bronchial wash, bronchoalveolar lavage, transbronchial FNA, and core biopsy. For more accurate histologic classification, mutation analysis, or investigational purposes, reasonable efforts, for example, a core needle biopsy, should be made to obtain more tissue than what is contained in a routine cytology specimen obtained by FNA. Overall sensitivity for combined use of bronchoscopic methods is approximately 80%, and together with tissue biopsy, the yield increases even to 90%. Like transbronchial core biopsy specimens, transthoracic core biopsy specimens are also preferred. Sensitivity is highest for large lesions and peripheral tumors. In general, core biopsy specimens, whether transbronchial, transthoracic, or EUS-guided, are superior to other specimen types. This is primarily due to the higher percentage of tumor cells with fewer confounding factors, such as obscuring inflammation and reactive non-neoplastic cells. Sputum cytology is inexpensive and non-invasive, but has a lower yield than other specimen types due to poor preservation of the cells and more variability in acquiring a good quality specimen. The yield of sputum cytology is highest for larger and centrally located tumors such as squamous cell carcinoma and small cell carcinoma histology. The specificity for sputum cytology averages close to 100%, although sensitivity is generally less than 70%. The accuracy of sputum cytology improves with increased numbers of specimens analyzed. Consequently, analysis of all at least 3 sputum specimens is recommended. Now about staging of malignant lung neoplasms. The lung cancer staging consists of 2 parts. First, a determination of the location of the tumor and possible metastatic sites, anatomic staging, and second, an assessment of a patient's ability to withstand various anti-tumor treatments, physiologic staging. All patients with lung cancer should have a complete history and physical examination, with evaluation of all other medical problems, determination of performance status, and history of weight loss. The most significant dividing line is between those patients who are candidates for surgical resection and those who are inoperable, but will benefit from chemotherapy, radiation therapy, or both. Staging with regard to a patient's potential for surgical resection is principally applicable to non-small cell lung cancers. You see here staging of non-small cell lung cancers. Regarding management approach, we have curative, intermediate, curative, and palliative forms. Curative are stage first A, first D, second A, and second B. Intermediate curative stages are stage 3A, 3B, 3C, and palliative are stage 4A and 4B, both 4 stages. TNM classification, we have curative. TNM classification includes T1, N0, M0 till T2B, N0, M0. And this means in case of T1, N0, M0, we have tumor size less than 3 centimeters, no regional lymph node involvement, no metastasis. In T2A, N0, M0 case, we have tumor size more than 3 centimeters, but less than 4 centimeters, no regional lymph nodes involvement, and no metastasis. About T2B, N0, M0. It means tumor size more than 5 centimeters and less than 5 centimeters, more than 4 centimeters, less than 5 centimeters. No regional lymph node and no metastasis. In case of T1, 2, N1, M0 means tumor size less than 5 centimeters, ipsilateral or peribronchial lymph node involvement, no metastasis. And T3 and 0 M0 means that tumor size is between 5 and 7 centimeters, no regional lymph node involvement, and no metastasis. Now intermediate, it was curative stage. Intermediate curative stages are T1, 2, and 2, and 0. It means that ipsilateral, we have nodules in ipsilateral mediastinal node nodules, but no metastasis. And in case of T3 to 4, N1, and M0, we have tumor size more than 5 centimeter, ipsilateral hilar or peribronchial lymph node involvement, but no metastasis. You see here that in curative and intermediate curative stages, we have always no metastasis. When metastasis appear, it's also almost palliative stage. Stage 3B includes T1 to 2 and N3. N3 means contralateral lymph node. When we have N3, it means that lymph nodes are on contralateral size, mediastinal or supraclavicular. N3, stage 3C, you see we have T3 to 4, N3, and M0. It means tumor size is more than 5 centimeters, contralateral lymph nodes, hilar, mediastinal, or supraclavicular, and no metastasis. And we see maximum N stage. We have third stage, and metastasis may be first AB and first C. It means metastasis in contralateral tube or pleural metastasis. This is M1A, and single extrathoracic metastasis, it's M1B. And last stage, fourth B stage, it means T1 to 4, N0 for 3, and M1C. T1 means any tumor size, N0 to 3, any nodule involvement, and M1C, multiply extrathoracic metastasis. Staging of small cell lung cancer includes curative and palliative, two forms, two stages we have. In a limited stage, we have T1 to 2 and 0 to 1, T3 to 4 and 0 to 1, and T1 to 4 and N2 to 3. Cancer spread confined to ipsilateral hemithorax, and approximately we have it in 30% cases. And palliative includes extensive stage. Now this is M1A to C. It includes only when we have metastasis beyond ipsilateral hemithorax, contralateral, supraclavicular, or hilar, lymph node involvement, malignant pericardial or pleural effusion, distant metastasis, and this is in 70% cases. Treatment of malignant diseases. Medical therapy includes chemotherapy indication for most lung cancers. Commonly used agents cisplatin plus a second agent, etoposide. Also, we have targeted therapy and immunotherapy. Targeted therapy, indication for targeted therapy are advanced or metastatic NSCLC with a demonstrated oncogenic mutation. Mechanism of action of targeted therapy is target upregulated pathways that cause expression of the malignant phenotype. Commonly used agents are tyrosine kinase inhibitors specific to the mutation or receptor monoclonal antibodies, EGFR mutations, ILK rearrangement, ROC1 rearrangements, crizotinib. In EGFR mutations, we have cetuximab, ILK rearrangement, alectinib. In ROS1, we have crizotinib. BRAF mutation, we have trametinib. About immunotherapy indications, locally advanced or metastatic non-small cell lung cancer, extensive stages of small cell lung cancer. The mechanism of action of immunotherapy alerts T cell function and improves intrinsic cell-mediated immunity. Blocks the PD-1 interaction, improving the anti-tumor effect of endogenous T cells, commonly referred to as immune checkpoint inhibitors. And commonly used agents are durvalumab, pembrolizumab, and atezolizumab. Radiation therapy. Radiation therapy is most commonly used in conjunction with chemotherapy in lung cancer, but it also has other indications in lung cancer management. Indications are limited stage SCLS, early or locally advanced NSCLS, palliative care for SVC syndrome, painful bone metastasis, tissue invasion, and hemoptysis to prevent or slow the growth of brain metastasis. Techniques of radiation therapy. Depending on the subtype of lung cancer and the therapeutic goal, different techniques are available. Concurrent radiotherapy and chemotherapy, primary radiotherapy. For example, stereotactic body radiotherapy. Palliative radiotherapy is external beam radiation and bronchial brachytherapy, and prophylactic intracranial irradiation. Surgical management indications are for surgical treatment, stage 1 to 2 and SCLS and non-small cell lung cancer without mediastinal lymph node involvement. Select patients with stage 3 NSCLS. Contraindications to surgery are N3 disease, bulky N2, multiply N2. Significant comorbidities of surgical treatments are high cardiac risk based on revised cardiac risk index and critically limited pulmonary reserve. Preoperative assessment is preoperative pulmonary function testing prior to lung resection surgery. You see here preoperative FEV1 less than 1.5 liter and DLCO less than 60% predicts a poor outcome after lobectomy. And FEV1 less than 2 liters and DLCO less than 80% predicts a pure outcome after pneumonectomy. How we treat NSCLS cancer in stage 1 to 2 with no metastasis. Typical treatment regime is preferred surgical resection with or without chemotherapy. Non-surgical candidates, with, for example, with inoperable disease or significant comorbidities, radiotherapy, stereotactic radiotherapy. Then, in curative cases, preferred surgical resection plus chemotherapy. Non-surgical candidates, chemotherapy plus radiation therapy, possibly adjuvant immunotherapy. And in palliative cases with metastasis, stage 4A to B, targetable mutation present, molecular targeted therapy, and no targetable mutation. In the case of no targetable mutation, chemotherapy and immunotherapy. Now, treatment in the case of small cell lung cancers. In limited stage, curative approach and curative patients, stages 1 to 2 and 0, consider surgical resection. In all patients, systemic therapy and concurrent radiotherapy and prophylactic cranial irradiation. In extensive stages, we have palliative situation. It needs chemotherapy with or without immunotherapy and consider PCI or MRI surveillance. Now about a few words about paraneoplastic syndromes. Paraneoplastic syndromes are a set of clinical features that are caused by either an altered immune response to a systemic malignancy or because of substances, for example, hormones, cellular proteins, produced by tumors. They are caused neither by the local mass effect nor by metastasis of the associated cancer. Paraneoplastic syndromes present with a wide range of findings and are most commonly associated with lung, ovarian, lymphatic, and breast cancers. Small cell lung cancer is especially notorious for its numerous and distinct paraneoplastic syndromes. Some paraneoplasias are associated with many different malignancies, such as tumor-induced hypercalcemia, which is caused by parathyroid hormone-related protein produced from tumor cells. Other paraneoplasias, for example, malignant acanthosis nigricans, are almost pathognomonic for specific malignancies, and their presence demands an immediate search for the underlying tumor. A general overview of the most common paraneoplastic syndromes and their associations is presented there. Further details for individual syndromes can be found in articles of associated conditions. And it was last slide, and thank you for your attention.